and good afternoon, and welcome to the next iteration of the ANZMIG AFWG webinar, which is run in conjunction with ISHAM. And tonight we'll have a couple of presentations focusing on drug-resistant fungi. With that, I will share my slides and begin, if I can find the correct button. Right. My name is Sharon Chen. I'm an ID physician and clinical microbiologist at Westmead Hospital in Sydney, and I'm very pleased to introduce my co-chair, Professor Tan Van Hoek, who is a specialist in infectious diseases and microbiology in Singapore. So today we'll start by a case presentation, and then we will have a panel of experts to discuss the case, which Professor Tan will introduce, followed by 2 talks, and then another case presentation accompanied by a talk. So I will begin. And first of all, we are in Australia, so we acknowledge traditional custodians of the lands on which we work and pay our respects to ancestors and elders, past, present, and emerging. These are my disclosures, and I was very pleased to attend ISHAM Asia in Bangkok earlier this month, and it was a great meeting, and I would commend all future meetings to all the attendees here tonight. So our story begins with Mr. XX. In the beginning, he was an 84-year-old man. He actually looked 65, from South Korea, previously well, and really had only had hypertension, but was a smoker. And in February 2020, this was the time that COVID hit Australia and everything seemed to coalesce into one rolling bundle. Anyway, Mr. XX presented with abdominal pain, having really not been sick before, some vomiting, some melena, some weight loss, and was telling us that his abdomen was just not quite right. Anyway, he had a gastroenterology opinion, and gastric outlet obstruction was diagnosed, had an outpatient gastroscopy, and a tumor was seen in the distal stomach. Before he could have more tests, he deteriorated with an upper GI bleed, which led to an emergency laparotomy in hospital. And at that time, what was described was a supracholic vascular tumor with pus and necrotic material seen that was adherent to the abdominal wall. Okay. He was admitted to the intensive care unit, and all sorts of drains, into him. With these drains, there were high amylase content, and his serum amylase was also high. He had a metabolic acidosis, and the preliminary pathology showed a neuroendocrine tumor of some sort. Because of this diagnosis, 3 days later, he had a modified Whipple's and a right hemicolectomy, standard intraoperative prophylaxis with antibacterials, no antifungal prophylaxis. Was started on TPN, became bacteremic, which responded well to antibiotic treatment, and the drainage ceased and decreased with clinical improvement, and he was weaned off TPN. So far, so good. And he was discharged to the ward about 14 days later. But a progress abdominal pelvis CT scan showed a complex pancreatic pseudocyst by 3, the largest of which was 12 by 12, originating from the stomach, so rather large. Pigtail stent was inserted into the largest one, and the others aspirated with drains left in situ. He received antibiotics, standard fare. Vancomycin was also commenced, and the culture of material yielded E. coli, very scanty, and Nakaseomyces glabratus, formerly Candida glabrata, heavy growth. Multiple sets of blood cultures were negative. He had multiple sets. 2 transesophageal echoes showed no vegetations, and a fundoscopy was essentially normal. So in this gentleman, I'll throw this up to the panel, and Ban Hock is kindly leading the discussion. These are the questions I have, and so over to the panel. Ban Hock?
Oh, thanks, Sharon, for sharing that very interesting case. So we have a panel consisting of 3 physicians who are quite illustrious in our region. So I won't take a long time introducing them. So they are Sarah Kidd from Australia, Orla Morrissey, also from Australia, and Arunaloke Chakrabarti from India. So perhaps I shall ask Dr. Morrissey, what should the next steps be in antimicrobial therapy for this patient with polymicrobial pseudocysts?
Well, I think the patient is on antimicrobials at the moment, and we don't seems to be reasonably well directed. But I would think that at this point in time, you need to think about adding in an antifungal agent. You know, sort of blood cultures are negative, and you know, sort of that's not unexpected when it's intra-abdominal infection. You know, sort of, so that could be negative, and you know, one would just think that's the sensitivity of the assay. One could think about doing, you know, sort of beta-D-glucan PCRs as well, but you've got the organism, so I'm not so sure about either of those being a necessary thing. So I think the next step would be to think about an antifungal agent, and then so I'm kind of answering the second question, but I'm happy to let somebody else do that as well.
Okay, so maybe we take the other question 4 first. What other test results would you like to see, Sarah? I think already.
Well, let me just point out that I am not a physician, and you do not want me going anywhere near this patient, but I do work in the lab, in the mycology lab, and I would like to see some antifungal susceptibility results on this isolate before commencing therapy.
Before commencing therapy? Okay.
Well,
okay.
You may start something. And
no, not before. But let's get on with it. Let's not waste time. Let's start antifungal susceptibility testing.
Arun, would you like to choose an antifungal?
Before answering this question which you have asked, I asked to ask Sharon, what is the sample from which the culture was this isolation? Is it that the...
Thanks, Arun. It's a good question. So this was fluid from the pancreatic cyst. And
pancreatic fluid.
Yes, so it was an intra-abdominal abscess which stemmed from the pancreas.
So if it is a pancreatic fluid, you have to start, because it's a surgical time after they have been collected. So there is nothing which I was feeling whether it is only from drain. If it is from drain, we have to think about the interpretation of the sample and the outcome of this. But as it from the aspiration from the pancreatic fluid, we have to start immediately the antifungal. And in this antifungal, the isolation, I agree with Sarah that we should do the antifungal susceptibility testing. But by the time it comes, at least we should start with some broad spectrum, looking into what can best work against Candida glabrata. I'm saying Candida glabrata because the new names is very difficult for the others to understand. So whatever it is, this Candida glabrata, if we have to manage, you know, this is around 30 to 40% isolates are usually resistant to fluconazole. And there is also some amount of resistance is coming up with echinocandin, but it is not more than 10%. But the issue of echinocandin is also important about the abdominal area, how much it gets concentrated. So for me, if I have to think about, I would start with amphotericin B liposomal. That would be the best way, start looking at it. And by the time I will wait for the susceptibility report, I can start also echinocandin, but I have now a bit hesitation of giving echinocandin in any intra-abdominal candidiasis. because what I've found that usual pharmacokinetics in case of the peritoneal fluid is not very good with the echinocandin. So either it is the liposomal amphotericin B or starting with the echinocandin.
Okay.
Okay, over.
Okay.
Van Hoek?
And-
Yeah.
How long would any of the panel, or does Dr. Morrissey, do you think, have any other suggestions? I personally would have thought an echinocandin was an acceptable option at the start in this patient.
Yes. Yeah, well, I think some of that will come up in my talk, so it'll be
Oh, okay, we
good
can
to
talk.
revisit it, which
Yeah,
is
okay,
quite nice. How long would I continue for? Well, I think sort of it's invasive candidiasis as opposed to just candidemia.
Yeah.
So you're thinking about 4 weeks, but it may well depend on how the patient actually goes as well. How they go clinically, how the radiology goes, ongoing culture as well. And so I would certainly sort of say around 4 weeks and reassess closer to that 4-week mark.
Yes, of course. Thank you. And I
But
suppose,
Debbie,
yeah, the important test
the-
result is the blood culture. Hopefully they did it.
the susceptibility should be back
And the
then as well,
susceptibility, yes.
which
Yeah,
Sarah's
Dr.
going to do
Marriott
for us.
has put in a comment that echinocandins have better activity against biofilms than azoles, and I think we take her point. Okay, I think we can move on, Sharon.
Okay.
Sharon,
So,
Sharon, may I ask you one question?
yes,
That in
of course.
case of this, you said that this is, have you done the beta glucan? You have not done the beta glucan.
No, we don't have access to beta glucan in Australia. I'm saying this half embarrassed, but we do not.
Why I asked you, because the question which is Dr. Morris has responded,
Yes.
the duration of therapy can be monitored to a certain extent, repeat beta-glucan test. That would help you in understanding how long you are going to give the therapy, because it's a real difficult question to answer how long to give therapy.
Right.
Okay, over.
That's a very good point, Arun. Thank you for that. And I also like your suggestion of the liposomal amphotericin B, but what happens in real life is what happens. This gentleman was cared for at Westmead, and it was our lab that performed the susceptibility testing. And, as hard as Katrina Halliday works, she can't work magic and kind of cough up the result in 2 seconds. So it takes about 2 days to get a susceptibility result, which is sometimes just not fast enough. So anyway, this is before the ID unit got involved. Antifungal therapy was started empirically, or sorry, not empirically, when we knew it was a glabrata, 800 milligrams daily was initiated in intensive care. There were lots of investigations to look for other end organ disease. There was a surgical consult because he had an intra-abdominal abscess, and there was an ID consult. And, you're all very astute in wanting the MIC results. So here are the MIC results performed by, Sensitida, and I think it was the E-test for savuconazole. And there we go. We have all the MICs with the interpretation. The fluconazole MIC was 64. So, we certainly didn't like the look of that. The MICs for all the other azoles were on the higher side with non-wild type MICs. They were susceptible to the echinocandin. So would this change your mind at all, Orla or Aaron?
Well, if you put them on amphotericin or you put them on rezafungin, you would be certainly from the susceptibility point of view on the right track.
Right.
So I think whichever one you had chosen. Well, sorry, you've put the patient on fluconazole. I'll take a step back. So you would need to
the surgeons did.
You need to change them.
We'll need to change it.
Sorry.
Okay.
It means more of a global U. But one would need to change it to something else from fluconazole. And then would be a decision as to what you think in terms of treatment of an echinocandin for intra-abdominal infection, as Arun has pointed out. And you may well plump for amphotericin, but some people may well also just plump for rezafungin as well.
Okay, all right. So progress, there was close monitoring of this man's pseudocysts and drain care, workup by oncology, turned out to have a pancreatic carcinoma, and he got looked after for that. And we hummed and hawed and decided that he should have an echinocandin. And as you've advised, Orla, 2 weeks isn't quite enough. 4 weeks, it might be enough, maybe even longer. He was actually quite well, apart from having this terrible diagnosis and having these abscesses. And we hummed and hawed about caspofungin or another echinocandin. And in the end, we thought that for logistic reasons, we would institute some rezafungin because we had access to that drug at that time. He did have 4 weeks in total. There was a good clinical response with marked reduction of the size of his pseudocysts, and repeat microbiological sampling showed no recurrence of C. glabrata. Unfortunately, in July 2020, due to his underlying diagnosis, he was admitted and he passed away then. But in terms of his candida abscesses, it was deemed that he had responded to rezafungin, which is a new anti-candida drug that we will be hearing about. So with that, we might save questions for the end of the webinar, and I think Sarah's going to give the next talk.
Yeah.
So Van Hoek, over to you.
Okay, thanks, Sharon. Good case. So now let's invite Sarah to give a talk on the antifungal resistance in Candida glabrata. Sarah, please.
Okay. So thank you. Those are my disclosures. And I guess I'll start with talking about drug resistance mechanisms. It seems a good place. So the azole drugs act by disrupting the ergosterol biosynthesis pathway by inhibiting lanosterol 14-alpha sterol demethylase, which is encoded by the ERG11 gene. And so ergosterol biosynthesis is reduced or halted, the cell membrane becomes depleted, reducing its stability, and sterile precursors start to build up in the cell, which become toxic to the fungus. So azole resistance in most Candida and former Candida species is primarily due to mutations in that ERG11 gene that reduce the affinity of the antifungal to its enzyme target, as well as overexpression of ERG11, which increases the concentration of sterol demethylase in the fungal cell. Another mechanism of resistance is the upregulation of efflux transporters, and in Nakaseomyces glabratus, azole resistance is primarily due to upregulation of the CDR1 and CDR2 efflux transporters due to gain-of-function mutations in the PDR1 transcriptional regulator. So as part of the WHO fungal pathogen priority list, a series of systematic reviews were performed, one of which was for N. glabratus. And this review, which was led by Justin Beardsley and published only very recently, it included 60 studies that reported on antifungal susceptibility of N. glabratus. And among these, the fluconazole resistance rates varied from 0 to 48%, although those studies finding no resistant isolates were considered to have a high risk of bias based upon the types of isolates that were included. And the study finding 48% fluconazole resistance was assessed as having a low risk of bias. So those studies with a higher rate of fluconazole resistance probably reflect more the reality. 16 of the 60 studies reported fluconazole resistance rates exceeding 10%. Then a 2022 study published by Castanera et al. Examined regional differences in fluconazole resistance rates. They used isolates that were submitted to the Sentry study, which included 561 isolates from 68 hospitals in 28 countries, and all of which were tested by the same CLSI reference method. They observed an overall fluconazole resistance rates of 6.1%, but these rates varied between regions, interestingly, with 2.7% fluconazole resistance observed among isolates from the Asia-Pacific region, where we are, 5.9% in Europe. There was no resistance observed among the Latin American isolates, although the number of isolates contributed from this region was relatively low. And the highest rate of fluconazole resistance was among North American isolates at 8.1%. Of the fluconazole-resistant isolates, just under 9% were co-resistant to an echinocandin and just under 3% were intermediate to an echinocandin, which is concerning. In the case we have just heard about, the isolate was multi-azole resistant, but fortunately susceptible to the echinocandin class. The echinocandin antifungals inhibit 1,3-beta-glucan synthase, which is located on the cell membrane and encoded by the FKS genes. And inhibition prevents the production of beta-glucan, and that leads to a depletion in the cell wall. So most Candida and former Candida species have the FKS1 gene, but Nakaseomyces glabratus has both an FKS1 and an FKS2 gene. And mutations in hotspot regions of both of these genes are generally acquired during therapy from echinocandins and are associated with clinical failure. So currently there are no commercial tests for the molecular detection of antifungal resistance in yeasts. And the main reason for that is that for azoles, at least, there are so many mechanisms for resistance which can be additive, and so many mutations linked to resistance that it's very difficult to design an assay that would detect a majority of resistant isolates. I guess in the case of N. glabratus, azole resistance is predominantly related to gain of function mutations in PDR1, and so perhaps it's possible to design an assay around that just for this species, but there are still many other mechanisms that could also contribute to azole resistance in this species. There are some in-house molecular tests for detection of FKS hotspot mutations linked to echinocandin resistance, but their utility has not been really defined in clinical trials. And so for now, we are still very much dependent on phenotypic testing for antifungal resistance. And broadly speaking, we have broth microdilution methods, such as CLSI or UCAST reference methods, also commercial broth microdilution methods like sensitivity yeast 1, automated methods such as the Vitek 2 platform, and agar diffusion-based methods. In terms of interpreting the results of susceptibility tests, it's only in the last 12 years that we've had species-specific clinical breakpoints at all for antifungals. And these are mostly for some Candida and former Candida species, and only for a handful of antifungals. CLSI and UCAST each have their own sets of breakpoints, and it's important to note that these breakpoints are different because they've been developed using different methods that yield different MICs. And not only are the breakpoint values different between CLSI and UCAST, which I'll show you on the next slide, but also the definitions that are attributed to each interpretive category are slightly different as well, and particularly for intermediate and susceptible dose dependent. So we really need to exercise caution with this. The interpretive criteria from CLSI and UCAST are not interchangeable, and we can only apply the breakpoints that are validated for the susceptibility testing method that is used in our lab. So clinical breakpoints for CLSI versus UCAST are available for echinocandins and fluconazole against N. glabratus. But you can see, comparing CLSI and UCAST, that the breakpoints are slightly different. There are no breakpoints for the other azoles there for either CLSI or UCAST. And it's also worth pointing out that there is no susceptible category for fluconazole versus N. glabratus. At best, they are susceptible dose dependent. In the absence of breakpoints, another tool we can use are epidemiological cutoff values, abbreviated as ECVs or ECOFs. So ECVs essentially define the upper limit MIC of a wild-type population of a species. So wild-type populations have MICs that are associated with the absence of acquired resistance mechanisms, and non-wild-type isolates have MICs that are associated with the presence of acquired resistance mechanisms. So isolates with MICs that are at or below the ECV would be considered wild-type, and isolates with MICs greater than the ECV for that drug would be considered non-wild-type. It doesn't tell us anything about the likely clinical response, whether it's wild-type or non-wild-type, and it doesn't confirm the presence or absence of a resistance mechanism. But what it does is it gives us a reasonable guide as to where that isolate fits into the overall range of MICs for that species. Is it quite a high MIC? Is it relatively low, or is it about average? The CLSI M57S document actually provides guidance to labs on using ECVs as interpretive criteria for laboratory reports. And so for those species with ECVs endorsed by CLSI, we can interpret the MICs as wild type or non-wild type and put that information on the lab report, assuming that the ECVs are appropriate to the method that we've used. And highlighted in red there are the ECVs for N. glabratus. Sorry, I think I've had that in the wrong place the whole time. These are for amphotericin B, itraconazole, posaconazole, and voriconazole. On lab reports, it's useful for MICs to be included, and I encourage labs to provide this information. Where clinical breakpoints are available, these should be used to interpret the MIC, and in the absence of clinical breakpoints, then we can use ECVs, assuming they're appropriate for the method that we use. And if there are no breakpoints or ECVs, then we can report the MIC without interpretation. So this is an example of how that can look on a lab report. The isolate that we've heard about in our clinical case earlier had high MICs to the azoles, and fluconazole was resistant. We don't have clinical breakpoints for posaconazole, vori, or itraconazole against N. glabratus, but we do have CLSI ECVs, and as Sharon told us, that classified these MICs as non-wild type. And if we're including wild type and non-wild type interpretations on the lab report, then we have to include some very detailed comments about what that means and what it doesn't mean. And this is the exact wording recommended by CLSI. And the comments stress that being wild type or non-wild type doesn't predict clinical response, but if we're planning to treat the patient with a drug classified as non-wild type, then that needs to be done in consultation with infectious diseases. Finally, when we encounter an MIC that is above the ECV and classified as non-wild type, remember that doesn't necessarily mean that the isolate is resistant, but it does mean that there needs to be some multidisciplinary discussions on whether the dose can be increased to improve the likelihood of success, or if perhaps another antifungal can be used instead. And I think I've gone a little bit over time, so I'll just stop there. Thank you.
Oh, thank you, Sarah. So I think in the interest of time, let's get on to the next talk, and then hopefully we'll have time at the end for the questions. So may I invite Orla now to talk about the role of rezafungin. Sharon's patient was treated with rezafungin, so yeah, let's hear about this very new drug. Orla Morrissey, please.
Thank you. Thank you for inviting me to talk here tonight. You can see my screen, can you?
Yes.
Yeah, great, excellent. I just want to make sure. Okay, so these are my conflict of interest statements. Okay, so rezafungin is a drug that's formerly been known as CD101 and SP3025. Originally was Sedara Therapeutics. this is important because this is the numbers, particularly CD101 is the numbers that will be referred to in tables as we go forward. It's a novel beta-D-glucan synthase inhibitor, and it's a structural analogue of anidulafungin. It has a choline, so this is the bottom one, number 2, is anidulafungin, and then the top one is rezafungin, and it has a change in the structure, a choline moiety on the cyclic hexapeptide ring. And what that actually confers to rezafungin is that it means that it's more stable, more soluble, and less prone to chemical degradation. And this may well then feed into the fact that it has a longer half-life, and why we can give it once weekly as a dosing regimen, that it may well have potential for topical and subcutaneous use, although that's not been very well explored to date, but has been to some extent. And it has got greater flexibility in terms of storage and manufacturing. Importantly, it's got increased tissue penetration, which is what I think Arun was referring to earlier. I'll talk about in my talk further on as well. So it has got strong in vitro activity, as you can see from this table. I won't go through it in too much detail because Sarah has already alluded to this, but C. albicans, Nakaseomyces, glabratus, C. tropicalis, and Pichia cuteosevi have got good low MIC values to rezafungin. The one for parapsilosis is an MIC of 2, but as we know, that parapsilosis has got a higher MIC against all echinocandin agent. But if you actually look at the proposed clinical breakpoint, anything that's less than or equal to 2 in terms of MIC has got a percentage sensitivity of 99.6%. But so most of them are sensitive if it's less than or equal to 2. So not only is it had good activity against a number of Candida species and Candida-like species, but also its equivalent, its MIC values. If you look down here, it sits really in the middle of the range for many of the Candida and Candida-like organisms as well. Perhaps for Candida parapsilosis a little bit higher, but certainly, as I said before, should sit within the proposed clinical breakpoint. It does have the same target as the other echinocandins, and therefore has the same mechanism of resistance. And there was one study which was performed where they looked at N. glabratus, and they had 5 isolates where the rezafungin MIC was greater than 1, and these also had an MIC of greater than or equal to 2 for the other echinocandins. And when they looked at the types of mutations, there was one that harbored a mutation in the FKS1 hotspot region, 2 in the FKS2 hotspot region, and 2 carried alterations of both the FKS1 and the FKS2 hotspot regions as well. So sort of seems to be that if you're going to get resistance, that's the type of resistance you're going to get. It's got minimal interactions with the cytochrome P450. Now, its extra advantages over anidulafungin is that it doesn't have any hematological or hepatotoxic effects, but sort of the hematological and hepatotoxic effects with anidulafungin aren't very high to begin with anyway, so it just makes it safer again. It's not removed by continuous venous hemofiltration. So if you're actually using dialysis or hemofiltration in the intensive care, there's no need to dose adjust it as well. It does have a post-antifungal effect similar to microfungin. That's particularly so for Candida parapsilosis. So a post-antifungal effect is that there's a continuing growth inhibition despite the removal of the drug as well. It is seems to be quite good against biofilms when you do a time-lapse microscopy studies, that it actually stops the adhesion and the early phase biofilms within minutes. It can also prevent the development of mature phase biofilms, and it can actually also eradicate biofilms that have already being preformed as well. So very effective against preformed biofilms as well. So in terms of prophylaxis, it seems to be effective as well. I know this is a talk about yeast, but I can't help myself put in to say that it's effective in prevention of infections for Aspergillus and Pneumocystis jirovecii. But I'll go back to Candida now. And in this study, what they did, this is a graph from a study where they immunosuppressed mice, and then they gave them rezafungin at different doses. So they gave it at 5 milligrams per kilogram, 10 milligrams per kilogram, and 20 milligrams per kilogram. And they gave it on day -3, day -5, and day -1, and that refers to the days before they actually gave the Candida challenge. So they gave a Candida albicans challenge, and they gave it intraperitoneally. And what this graph really shows is that at the doses of 10 milligrams per kilogram and 20 milligrams per kilogram of rezafungin, you essentially got no growth when you took out the kidneys and homogenated them. So it seems to be very effective in preventing Candida infection. So that's interesting data to have on how it actually works. Now, this comes back to what Arun was talking about earlier about intraperitoneal infections, intra-abdominal abscesses, and maybe not the drugs not having any efficacy. And this study looks at abscesses in the liver and cross-sectional sections taken at different times, and compares micafungin to rezafungin. And with micafungin, that sort of actually isn't taken up into the liver for about 6 hours after a single dose, and actually requires multiple doses to get any effective activity within the necrotic tissue. Whereas with rezafungin, uptake begins after a single dose within 8 hours, within 3 hours of giving the rezafungin. And as you can see on this nice red slide in the middle here, that it actually is penetrating the necrotic tissue quite well, within 6 hours, and that's 6 hours of a single dose. So it does seem to have better tissue penetration than the other echinocandins, and so may well be very useful in the setting of these sort of abscesses compared to other echinocandins. But I think we need more data, particularly human data, for that. Again, this slide shows the graph actually is just a graphical representation of that, and it's really the dose, the concentrations within the lesions. And as you can see, that even a 5 milligram dose of rezafungin is greater than a 5 milligram per kilogram dose of micafungin, and 20 actually gets greater penetration into the lesions, or greater concentration within the liver lesions. Looking at Candida auris as well in another, again, murine model, and when they give the patient, give the animal Candida auris, and then start treating them on day 1, day 3, and day 6 with rezafungin at 20 milligrams per kilogram, it institutes a greater log reduction in tissue penetration, or in terms of tissue infection, particularly the kidneys, as compared to micafungin, amphotericin, and the vehicle as well. This is some data on the population pharmacokinetics. One of the important things is got a terminal half-life of 152 hours when it's given as multiple doses. When it's given as single dose, it's got a terminal half-life of about 80 hours. So a long half-life, which allows us to do intermittent dosing. However, importantly, in sick patients, the area under the curve and the Cmax decrease compared to the healthy volunteers. So we may well have to think about higher dosing in more sick patients as well. So looking at clinical data, there's 2 studies. There's the STRIVE study, which was a phase 2 study, double-blind study, which was done in 44 centres in 10 countries globally. And what was looking at was the safety, tolerability, pharmacokinetics, and efficacy of rezafungin compared to other drugs. So they did part 1 and part 2 in this study. Part 1 was, as it is described here, 400 milligrams weekly, compared to the other arm with 400 milligrams loading, 200 milligrams weekly then of rezafungin, or caspofungin, which got 70 milligrams loading dose, 50 milligrams daily, and you could actually step down to fluconazole. So that was part A. In part B, and they were randomized 1:1:1. In part B, they actually just had 2 arms, where they were actually 2:1. So they actually didn't have the second arm of the study. They looked at a primary efficacy outcome of overall response, which was defined as overall cure, which was resolution of clinical signs and symptoms of candidemia, mycological eradication, and radiological cure as well. And then mycological response was success was mycological eradication, whether it was presumed or documented, and there was no change in antifungal therapy. Failure was persistence, presumed or documented, and indeterminate was they actually were lost to follow-up or didn't have a specimen to be able to make an assessment. There were a number of secondary efficacy endpoints, but there was also safety outcomes as well, such as adverse events and treatment emergent adverse events. All-cause mortality through to follow-up as well was an important safety outcome as well as vital signs, laboratory and ECG testing. So the overall combined Part A and Part B, when they put all the data together, they found that the dose of 400 milligrams initial dose followed by 200 milligrams weekly of rezafungin gave the highest overall cure rate compared to the 400 weekly dosing of rezafungin compared to the caspofungin once daily as well. So in addition, the graph also shows that there seemed to be earlier clearance, and this was statistically significant for rezafungin compared to caspofungin as well. So there was more rapid clearance of the Candida infection as well. These are the side effects that were actually reported, and again, pretty similar across the board. And for the 400-200 milligram regimen of rezafungin, the all-cause mortality at day 30 was the lowest compared to 400 or the caspofungin dosing regimen. So the RESTORE study then was a phase 3 study, and they carried forward some of the data from the phase 2 study into the phase 3 study. Again, it was a double-blind study. It was done in 66 centres in 15 countries around the world, and it was for patients who had microbiological confirmation of candidemia or invasive candidiasis in the 96 hours prior. There were 1-to-1 randomization where they got rezafungin as in a 400 initial dose and then 200 milligrams weekly for a total of 2 to 4 doses, or caspofungin 70 milligrams daily on day 1 as a loading dose, and then 50 milligrams daily thereafter for a maximum of 4 weeks. They had 2 primary endpoints, one for the European Medical Agency and one for the FDA. The primary endpoint for the European Medical Agency was global cure, which was clinical cure, radiological cure, and mycological eradication. And for the US FDA was 30-day mortality was their endpoint, and the non-inferiority margin was 20%. And then, of course, they had safety endpoints as well. So this is just the disposition. I'm not going to go through it in great detail, but they actually consented 222 patients, 199 were randomized, 100 to the rezafungin arm and 99 to the caspofungin arm, and they ended up with 77 patients clinically evaluable in the rezafungin arm and 82 that were clinically evaluable in the caspofungin arm as well. In terms of the endpoints, the global cure for the EMA was, sort of not statistically significantly different. So rezafungin was not non-inferior, and similarly for the FDA endpoint, again, it was not non-inferior as well. Again, there seemed to be greater clearance of rezafungin of the candidemia in the patients who got rezafungin compared to the caspofungin. So the blood cultures became negative much more quickly with the rezafungin. In terms of the side effects, sort of again, pyrexia, hypokalemia, pneumonia, septic shock, and anemia were the top 5, and they were the ones that occurred in at least 5% of patients, or over 5% of patients in the study as well. And adverse events overall were about over 50% for each group of the arm, for each group of the study, or each arm of the study, and there was no real difference between the two of them as well. So in summary, I think we can conclude that the FDA have approved its use for patients who are 18 years of older who have limited or no alternatives for the treatment of candidemia and invasive candidiasis. It seems to have enhanced stability, and it's concentration dependent. It appears to result in an early mycological response, and it seems to be very susceptible to high front-loading exposure as well. It appears to have better tissue penetration from animal studies, but we need more clinical data on that. Seems to be very safe with limited drug-drug interactions. And so from a kind of, I suppose, a stewardship point of view, some of the advantages are that it results in a reduced length of stay, and it results in a reduced length of long-dwelling intravenous catheters as well, which may well have flow-on effects in terms of complications of catheters as well. So I think we can say that it seems to be a valuable addition to the antifungal armamentarium.
Thank you very much, Orla. I wish to remind the participants that they can put questions into the Q&A, and then we will take questions when all the lectures have been given. So to stay on the topic of resistance, antifungal resistance, but to move slightly away from Candida glabrata or Nakaseomyces glabratus, I now invite Abby Douglas, who is an ID physician from Peter Mac in Melbourne, to do a presentation on one of the most resistant of the fungi, Lomentospora prolificans. Abby, please.
Thank you, Tim. Can you see my slides?
Yes.
And you can hear me? Sounds good. Okay, thanks, Orla. All right, thanks for inviting me to talk on this topic that's close to, I think, Australians' hearts, for better or worse. Here's my disclosures, which are minimal. So an outline of my talk will be that I'll present a very interesting and challenging case that poses a number of questions and queries about where to from here. And then I'll go into the background of Lomentosporiosis and scedosporiosis and the potential role of olorifim in this very difficult to treat condition. So our case, with special thanks to Dr. Ash Thomas for some of these slides and summarising the case, is a 71-year-old lady who was independent from home with her husband, who unfortunately was diagnosed with metastatic melanoma. She had minimal other comorbidities. And so the diagnosis was made in July of 2022, and unfortunately she had axillary lymphadenopathy and cerebral metastases on diagnosis, and had some targeted radiotherapy and was commenced on upfront dual immunotherapy of nivolumab and ipilimumab. As not uncommon in this scenario, patients can develop immune-related adverse events from the immunotherapy, and in this case was one of the more severe manifestations being severe colitis. And in this case, it's a life-threatening condition and is taken quite seriously. She was given pulsed methylprednisolone, salvage infliximab, and then a weaning course of prednisolone over the following months. So we are now reaching December. So she was diagnosed in July. This is December, still on prednisolone 25 milligrams. And she developed a left-sided scotoma with some facial dysesthesia or abnormal sensation of that side of the face. Of course, she had a number of investigations at that point, one being an MRI brain that showed some subtle thickening and enhancement of the left globe with a little bit of retrobulbar enhancement. CT sinuses showed very mild mucoperiosteal thickening, but no invasion of the bone or anything particularly suggestive of fungal sinusitis. And a kind of pan-scan CT chest over pelvis showed some mostly stable small pulmonary nodules that were thought to be to do with melanoma, although there were two further small nodules with an arrow there showing kind of size, which is quite small and well circumscribed. In the context of this eye concern, a number of things happened, of course, one being blood cultures were sent off, including microlytic blood cultures, which were negative. We urgently involved our ophthalmology colleagues who had performed a left vitrectomy on the 16th of December and injected intravitreal voriconazole in addition to antibiotics. The histopathology just showed granulation tissue with negative fungal stains. However, the chorioretinal biopsy did grow Lomentospora prolificans. In that setting, in line with guideline recommendations, she was commenced on voriconazole and terbinafine dual therapy. Not entirely surprising for Lomentospora were very high for the standard antifungals, including voriconazole, but nonetheless, the best treatment that we have available is voriconazole terbinafine, and we'd always take the MICs with a little bit of grain of salt, as they're not the most reliable in this type of pathogen. She had a PET scan around that time, which showed that she had changes of the globe consistent with her recent surgery. There wasn't any further avidity around the orbit, very mild axillary lymphadenopathy, nothing else uptake elsewhere, including the heart. She did have an echo nonetheless, which showed normal valvular morphology and ventricular function. She was discharged home with on voriconazole terbinafine for outpatient follow-up. However, whilst she had the vitrectomy in mid-December, we were still having trouble getting good voriconazole levels in this lady, despite multiple increases in the dose of the voriconazole. And despite being subtherapeutic, she actually had visual symptoms that worried her. So even without being in a therapeutic level, she was getting troubling symptoms. She had a further MRI to assess what may be going on with the visual symptoms, and the MRI showed a bit of hemorrhage in the vitreous, which is not entirely surprising, and a little bit of fluid in the mastoid air cells, which were a little bit difficult to interpret, but went forward for a CT temporal bones, which showed a minimal thickening, but no bony erosion, nothing to suggest invasive fungal involvement at that point. Given still, though, that we really didn't know where this fungus had come from in the first place, it had landed in the eye, of course, but was it from the sinuses in the first place? So the degree of suspicion or index of suspicion was high enough that we involved the ENT colleagues to have nasendoscopy and biopsies and washout, but everything looked very clean, clear mucosa, and the histology agreed with that without any evidence of fungus, and the culture was negative. However, she did start to complain of some progressive swelling of her maxilla and increasing proptosis, so there was still the concern that the eye itself was failing the antifungal therapy, and she was switched over to olorifim, 90 milligrams BD. And it should be said that along in the entire course of this treatment, we had been suggesting enucleation of this eye because we were very worried about failing medical therapy, but it took a long time to come to the realisation that we probably weren't winning with medication alone. And so eventually she went on to have an enucleation of the eye, which confirmed granulomatous panophthalmitis with fungal hyphae. They unfortunately didn't send cultures, which I'm sure we've all been frustrated by before, but nonetheless, it looked like it was very much the fungus that was still driving things. So she's had her enucleation, which hopefully should be some degree of source control, and continued discharge on olorifim 90 milligrams BD. She had follow-up PET scans, which showed a little bit of maxillary sinus avidity, but nothing major in that area. However, she developed this cardiomegaly and bilateral pleural effusions, which were brand new in a lady who had a pristine heart prior. So this was very concerning. And on further questioning, she did report that she had some dry cough and exertional dyspnea in the couple of weeks leading up to this. So this is about 6 months after the initial diagnosis of the Lomentospora. And she had an echocardiogram, both transthoracic and transesophageal, which unfortunately, so both aortic and mitral valves had significant regurgitation with some thickening, and was very concerning for endocarditis. She had blood cultures collected, which did not grow the Lomentospora. She, given her tenuous hemodynamic status and the fact that we suspected this was fungus, went forward for tissue valve replacement, aortic valve and mitral valve. And there was definitely pus seen on the mitral valve leaflet, including into the aortomitral curtain. So there was extensive infection there. She was given some antibacterial therapy for a period of time until cultures returned, but not entirely surprising, Lomentospora prolificans was grown on the valves. It was at this point that the questions about, was olorifim enough? Was it working? Do we need to re-add voriconazole and terbinafine? These questions are very hard to answer. We don't have trials, but in the absence of other options, we decided to add in what best we could, which was combination voriconazole, terbinafine, and olorifim. She did then still struggle with symptoms from the voriconazole, with visual symptoms, some LFT derangement, nausea. So it was, again, a struggle. And we dose reduced the olorifim after discussion with the drug company, as they suggested that it's best to dose reduce given the interactions when on voriconazole. Unfortunately, she still had resurgence of fever day 10 post-op, and nothing much else found on pan scanning. And unfortunately, it was only day 10 post her actual procedure that she actually finally grew the Lomentospora prolificans in the blood, despite having endocarditis clearly for many days. And as you may imagine, things were not going well at this point. And unfortunately, scans showed that she had a new splenic infarct. She had ongoing fevers. She was not thriving. There was up and down about the olorifim and voriconazole dosing, and concern about whether there was interaction that might be antagonistic. So there was a lot of questions that we didn't have answers to, which we'll go into in a minute. Eventually, it was clear that she was really not improving despite aggressive surgical therapy, aggressive antifungal therapy, and she was discharged home to her family for end-of-life care. And she passed away day 36 post-operatively. So this was obviously a very sad case and a very florid case, and olorifim obviously wasn't the saviour in this case, but we've got lots of some interesting discussion going forward here about what olorifim may be able to offer in our patients where we have very limited options otherwise, and perhaps if olorifim was instituted earlier, we may have seen something different, but we don't know. So unfortunately, Lomentospora prolificans and Scedosporium species, in particular Apiospermum, are particularly an Australian conundrum. This graph here on the right shows you the estimated incidence per million. And so Australia is a hotspot, as well as southern western United States, as well as Spain, but there are reports of cases elsewhere, as you can see in India and Korea as well. And because of our preponderance of cases, we have offered a lot to the literature in this area, and Zoe Neo and many of the ANSMIC crew contributed cases of Lomentospora prolificans and Scedosporium in a multi-centre 6 tertiary centre study over 15 years, and 61 cases were amassed and 37 were Lomentospora prolificans. And interestingly, what was gleaned was that Lomentospora prolificans tends to be in the most heavily immunosuppressed patients. So classically hematologic malignancy, typically also transplant, stem cell transplant, and a small number had diabetes either concomitantly or as their own risk factor. As opposed to Scedosporium species, which tended to be a little bit less immunocompromised, renal transplant was common, chronic kidney disease, and then the traumatic inoculation style presentation with skin and soft tissue infection was more often seen in Scedosporium. Now, with the Lomentospora prolificans that we're focusing on at the moment, these are beautiful pictures, courtesy of Sam Baumgart of this filamentous fungi that we now know and love or hate. Unfortunately, with Lomentospora prolificans, most of the time there is dissemination in these heavily immunocompromised patients, and it presents similarly to many of the other disseminated molds, such as Fusarium, and Aspergillus, and in some ways Mucor, with lung as often a primary source, dissemination to the CNS. It can be grown in blood with Lomentospora Scedosporium, and you can have necrotic skin lesions that can also be a clue. Interestingly, with our case with the endophthalmitis, looking through the Australian case series, there were 3 other cases of endophthalmitis reported there. So it is something that is seen. As far as other organs, it could be any number of organs involved. Very few cases of actual endocarditis reported in the literature, only 8. This is another beautiful picture from Sam Baumgart about on a sabrodextrose agar plate of the Lomentospora prolificans morphology. And as far as treatment, the treatments are extremely limited. So if you do susceptibility testing on these isolates, particularly for Lomentospora prolificans, it may in fact be non-susceptible or not susceptible for all antifungals tested. But the ones that seem to have the best activity, at least clinically, are a combination of voriconazole and terbinafine. This is not in randomized trials. We do not have that level of data, but this is in case series. For Scedosporium species, we tend to go with cell therapy with voriconazole. Clearly, surgical management is important if there is something that can be debrided, particularly skin and soft tissue. We very much encourage surgical management where possible. The outcomes are dismal because of the lack of treatment options. And so in the Lomentospora prolificans subgroup, those heavily immunocompromised patients, about 70% mortality at 1 month was observed. And the death can be extremely rapid in these patients. The median time to death was 6 days. And so in many ways, sometimes the culture in the blood classically can come back after the patient has actually died. And so it's there, but it can be a terminal event showing that the patient has a very terrible immune system. There was, however, a 22% 18-month survival. So there is some hope in some patients, particularly if there is some surgical management and early recognition. For Scedosporium species, a better news story, still about a 22% mortality at 1 month, a longer median time to death, and 70% survive to 18 months. So what about olorifim? Olorifim is exciting for us ID physicians because it is a novel class of antifungal after many years of having the standard 3 or so classes of antifungals, and it's an erotomide. It targets pyrimidine synthesis and therefore has impacts on cell wall integrity of fungi, and has a very large volume of distribution, which includes the eye and the CNS, which is quite attractive. It's available in oral and IV formulations and has very good oral bioavailability. As far as what it covers, it has good activity against most Aspergillus species, and as mentioned, Scedosporium and Lomentospora prolificans, some endemic fungi, Tularamyces. Interestingly, Variconus gallopava was found to be quite active against this in the recent work by Katrina Halliday and the Westmead group, and has some activity against Fusarium oxysporum, but not really Fusarium solani. But still, that's good. We have the limited options in Fusarium. Importantly, no activity against yeast or the mycorrhizales. So unfortunately, mycorrhizales are still searching for a good drug for them. As far as how do you prescribe olorifim, it's suggested by the drug company that you give a BD load, so 2 doses of 150 milligrams, and then 90 milligrams twice daily ongoing is the recommended dosing, and can be increased by increments of 30 milligrams BD as needed, up to a maximum of 150 milligrams BD. They do recommend monitoring LFTs because, if anything, that is a bit of a liver function derangement has been observed. TDM is not widely available. It can be sent to the Netherlands, and so there is kind of increasing data needed to understand how much TDM is required for this drug. As far as clinical data on olorifim efficacy, we only have a kind of trickle of data coming through with case reports, particularly from hospitals that have had compassionate access to olorifim and have had success in this space. And as far as published information, an abstract from ID Week in 2022 reported on the first 100 patients who received olorifim in their phase 2 open label study. And the overall response, which included complete and partial, was actually quite promising. So remembering that for the invasive Aspergillus, patients that were recruited to the study are those who were failing other therapies typically, and so had good success at day 42 and day 84. And also for Lomentospora prolificans and Scedosporium, they actually had quite promising outcomes for a condition that usually has a terrible prognosis. granted that you had to survive to get to the olorifim. So patients may well have had their rapid florid septic deterioration and death, and so there is a bit of a survival bias here. But nonetheless, in those who survived the early phase and are still having troubles with perhaps voriconazole levels or tolerance or whatnot, or just failure to improve on imaging, there was some good success there. And for those infections that take longer to respond, including brain CNS infection and bone osteomyelitis, a stable response at 84 days was predictive of actually having an extended therapy response. So there was promising signs for those more deep brain and bone infections. There is concern, however, about the azole and olorifim interaction and whether there's a degree of antagonism that may occur between these agents, which has huge implications for how we manage these patients. So the concern is that azoles do upregulate the pyrimidine biosynthesis, which is the mechanism by which olorifim works, is inhibiting biosynthesis. And in these lab-based studies in vitro, the presence of an azole in Aspergillus fumigatus increased the MIC a fourfold for olorifim, including in those that were technically azole resistant. In the Lomentospora prolificans treatment, there was combination therapy allowed in the phase 2b study that I reported just before, although there's very minimal information because I only have the abstracts. But the drug company do recommend that dose reduction to 60 milligrams BD, and that's what was done in that phase 2 study. And so there was success in those in several of those patients. So. But whether it could have been even better success without the azole, we don't know, and we need more clinical data to confirm if that's a true problem or not. And so the other concern, of course, this is a brand new, fantastic, well, we think it's a good drug that will be a treatment option for a very difficult to treat condition. But could there be resistance that emerges? And unfortunately, in Aspergillus fumigatus, there have been early reports of a small number of emergent cases of erotomide resistance, at least in vitro. And many of you may have heard about the environmental fungicide prolificans, which is basically an analogue of olorifim, which is being used in agriculture. In Australia, it's being used to spray strawberries to prevent fungus on strawberries. And unfortunately, there is at least a proof of concept that the prolifican can induce cross-resistance to olorifim. So we are very concerned about that and are lobbying to try and reduce the use of that in agriculture. What about in Lomentospora prolificans? We haven't seen any clear evidence of resistance, at least from an in vitro and MIC level. These are published studies, including from Australia, from the Westmead Group, showing that so far MICs have been very low to olorifim for Lomentospora prolificans. So far, we haven't really seen any high MICs amongst these isolates. So the take-home points I would say from this case and from the discussion we've had is that Scedosporium and especially Lomentospora prolificans are very difficult to treat infections in heavily immunocompromised patients typically. And at the moment, as far as registered drugs, we don't really have much to treat these patients with. And voriconazole is extremely problematic as far as getting the correct levels and tolerance for the patients. And patients clearly fail voriconazole and terbinafine, and olorifim is promising in this landscape. And we're very eagerly awaiting more formal publication of the FTG company's data. And I think one question that's definitely unanswered is how does olorifim perform upfront as first-line therapy? Because at this point, what we're seeing is a salvage in a selected group who've managed to survive that immediate early death that some people have who are heavily immunosuppressed. And we really don't know what to do with the combination therapy and whether that is a real problem of antagonism versus a theoretical problem. And with that, I thank you for your attention, and especially thank Dr. Sam Bongard and Dr. Ash Thomas for their assistance with these slides, Prof. Sharon Chen, Caitlin Kiley, and the NCIC group. Thank you.
Thank you very much, Abby. A great case and a learned disquisition. So I think it's Q&A time. I invite all the participants once more to put their questions into the Q&A box, but there are quite a few that have been posed actually by members of the panel. So maybe while the audience is thinking up their questions or overcoming their shyness or inhibitions, maybe we let's ask a few questions now. So Orla, Arunaloke wants to know, in Sharon's case, if you also had access to Ibrexta funga, would you choose Ibrexta funga over rezafungin?
I think it's very difficult to say which would be best because there's been no comparisons between the two done. I would probably say that just working from first principles, since that the rezafungin is working very well in this patient, I will continue it. I perhaps maybe if the patient hadn't been doing so well, you might well want to think about it, but I wouldn't be changing horses at this point in time.
Okay, thank you very much.
If I just respond, Orla, in case of this Ibrexta, the studies in case of the animal, it had shown it gets concentrated in the intra-abdominal condition. So the concentration of Ibrexta goes very high. That's the reason I asked if we have to compare between these two, in that though there is never will have a case-to-case study or comparison between this in clinical trial, but just on that basis, I asked you that question.
Yeah.
Okay.
Yeah. I think also, you know, sort of that some of the animal data for rezafungin also show similar characteristics as well. So yeah, again, you know, sort of both are encouraging, but I think that given he was doing well, I would stick with where I was.
Thank you. Thank you, Orla and Arun. There's a very interesting question here, which I also thought about. Although in the STRIVE study, 400, 200 did better than 400, 400. Do you know why? I think Caitlin also asked that.
I couldn't find any reason as to why it would be. You would expect that, you know, 400 would be better. But you know, sort of that's the data that came out. So I can't think of any reason, you know, unless you supersaturate and you just can't get any higher levels than that. Might be the reason. Sharon's put up her hand. She might have a magical reason that I haven't. Don't know.
Sharon?
Orla, I don't have a magical reason, but one of my questions to you was that this is an intermittent dosing of rezafungin. So if you take it that it's an AUC under the curve function, is the level given once a week adequate to last, and does it worry you that we're not doing TDM? Or does it worry you that the intermittent dosing might predispose to resistance? Which might be one reason why your 400 and 400 is pretty, equivalent, because it's your area under the curve.
It might well be, yes, the area under the curve. I think the only way you're going to figure out whether it's adequate dosing is to actually do a TDM study, sort of, and take levels at different time points in that weekly regimen, that's probably the only way you're going to actually find out whether there's adequate levels or not.
Thank you.
Okay, but maybe we go back to this Nakaseomyces glabratus, which was the focus in the beginning. And this is a common conundrum, and someone in the panel has asked it. What would you do for Candida glabrata in the urinary tract that's fluconazole resistant, not even SDD? Maybe we start with Arun, and then we can go around and see what.
I would prefer in that scenario, thinking that if we can have these other drugs available, like in case of this, if it is amphotericin B or polyene with 5-FC combination, because 5-FC can take into this scenario, and this combination has been recommended also in case of this UTI with Candida glabrata, if it is resistant to fluconazole. So that combination possibly might be useful.
Orla?
Yeah, that's a very difficult one. Sort of maybe rezafungin might be, sort of worthwhile. I do take the point that, so it's not necessarily supposed to penetrate into sanctuary sites of candidans, but maybe rezafungin is a different agent, and I would, sort of have to look up that data, but I didn't find it when I was actually doing my review, but it certainly might be something that we might worth think about. Maybe some of the newer antifungal agents like abrexafungerp might be also worthwhile thinking about as an agent as well. So I think the new agents may well open up avenues that are better for this very difficult case.
Thank you. What about Abby?
Oh, about me? Yeah, I was just looking. There was a poster at ECMED about abrexafungerp being UTI in a small case series, but had quite good success in Auris and glabratus. So I think it may be that comes up as an option. We really don't have much access to abrexafungerp as far as I'm aware in Australia at this point, but hopefully is an option for the future.
For the future, yeah. Sharon, would you like
to? Nothing really to add, Bunhock. I agree with everything that's been said, and it's an extremely difficult situation. I'm just glad that what I guessed at the outset of the case was probably what the panel would have done as well. So I'm feeling relieved.
Yes. I think the only other thing to add is that foreign bodies should be removed if possible.
Yep.
I think, yeah, catheters and stents, but that all easier said than that. Okay, an anonymous attendee mentions that there is a striking difference between intraperitoneal concentration of rezafungin versus other kind of candins. But as we know, rezafungin is not readily available in most countries. So in cases of complicated intra-abdominal infections / abscess, should be dosing other kind of candins at much higher doses. Yeah, maybe various members of the panel can chime in. Arun, and then we can ask Orla.
No, I would say that here, in a complicated scenario, the rezafungin in this aspect, that's why I asked the question to Orla, that whether we cannot go with the Ibexa, because that is getting concentrated in this, because I am really excited in this issue that because echinocandin has a serious issue in case of intra-abdominal candidiasis. And because of not reaching that proper concentration in the intra-abdominal fluid and causing this problem, I'm more thinking that if Ibexa is allowed at least in vulvovaginal candidiasis, and possibly you can possibly use in this scenario, if it is out of this, you can try this. I have no experience, but I'm just saying that the literature going through it, because intra-abdominal candidiasis is a very serious issue now in India. And managing such patients is becoming a big problem. And that's why I'm looking for such solution into this. And we have the problem with the Candida auris. That's another issue. You are discussing Candida glabrata, but Candida auris causing intra-abdominal candidiasis is now a big problem in our ICUs.
Yeah, thank you, Arun. Orla, would you like to take this up?
Yeah, look, I think that if you have availability to other agents, they were probably worthwhile thinking about. But if you don't, and I think sort of if you're still faced with these intra-abdominal infections, you might well have to up your dose of anaconda. And certainly higher doses can be used. They're used in other circumstances, such as critical care, obesity, so there's no reason why we couldn't think about using them in higher doses. I suppose they may well have more ceiling or lower ceilings compared to rezafungin, but I think certainly you could think about that. But if you have access to rezafungin or you have access to rezafungin, then you may well want to use those as alternatives. Then the other thing is that we mustn't ever forget is amphotericin. Amphotericin does have sort of good penetration as well, and sort of particularly in the lipid formulation where it's less nephrotoxic. I think it's also worthwhile remembering that as well as an alternative.
Yeah, these are difficult patients because many of them with the sepsis, polymicrobial sepsis, etc., they always have AKI as well. And amphotericin is very difficult. Liposomal amphotericin is less nephrotoxic. You're right. One question for Abby. In CNS Guido, where we can only access oral compassionate access olorofilm, would you stop voriconazole and terbinafine when starting olorofilm?
I think it's a difficult question because we really don't have the data in granular detail published as yet. We've got initial data in abstract form presented. So I think it'll be really helpful to have the phase 2 study to really study, examine in detail, because we don't know, is the voriconazole terbinafine plus olorofilm a problem, or is it just dose reduction? And we do know that olorofilm does get good CNS penetration. As far as clinical data on CNS outcomes in granular detail, again, we don't have that information. And it does have quite good oral bioavailability. So I think you wouldn't necessarily have to switch to IV. You could, if you had the nasogastric route, if someone is unconscious, they could still get it via the nasogastric route. But there is potential access to IV with the drug company if needed. I think if I were faced, again, with someone with CNS, scedosporiosis or Lomentospora in particular, and we were really up against it, I probably would still do combination and do the dose reduction of the olorofilm to 60 BD, mainly because I don't have that confident clinical data about just having olorofilm. And I would like to still be confident that at least voriconazole I know does get into the CNS very well.
Thank you very much.
And levels, we don't have levels either for olorofilm.
No, we don't. Yeah. Let's go back to Candida glabrata. I think Arun asked Sarah a question whether or not they look for heteroresistance. Maybe we can have a little discussion on that, Sarah.
Not sure where to start. The answer is we don't check for heteroresistance. I'm not exactly. I'm going to let Sharon jump in maybe, but I don't know probably where to start with that for testing. Sharon, can you save me?
We don't do it either, Sarah, because
it
means kind of microscopically examining your columns to see whether they're petite mutants or not. And yes, you could find some with highish MICs or lower MICs, but it's a lot of work, so we don't do it. And as Arun was saying earlier this evening, about 30% are resistant, and they're quite resistant, so we don't do it. Purely because we don't have the resources to do it.
So
I will say sometimes on the plates that we do see in what we hope are, pure subcultures, we see sort of big colonies and small colonies, and sometimes we'll put in the effort to test those separately, and invariably it's made no difference to the MICs for us.
We do that too. We can find colonies, but it's difficult to actually pick out the petite mutants. I don't know, Arun, do you do that in your lab?
Basically, I faced this problem and I went to the literature, and then I found that both heteroresistance after crypto has got very good idea about heteroresistance. After that, it is the Candida glabrata which has got the heteroresistance. Similarly, tolerance issue is also coming in Candida glabrata, because certain times it is very difficult to manage some patients with Candida glabrata, either having intra-abdominal infections, invasive candidiasis, and those are the issues where there are some of the studies which have come up. If you want those studies, I'm just going through those and trying to understand a bit more about this heteroresistance in case of the outcome of Candida glabrata vis-a-vis in case of fluconazole, because we generally say increase the dose if it is intermediate in case of this Candida glabrata. But then the question comes, if there is heteroresistance comes into the same colony, you have got few strains that would come up and show outcome which is not good. So that's why I'm saying I want to learn from Shara. That's why I wanted to put that
it's a very good
question.
And we haven't done it because I think to do this properly, you would need a phase microscope and a few other things, and perhaps we should start seriously thinking about doing it, but we haven't. I don't mean to change the subject, but can I just comment about what Abby said in her combination therapy comment? So I think Abby's absolutely right. We need the data from the phase 2b study that is coming out. And if we all remember, in the early stages of the phase 2b study, you couldn't use olorifim in combination. That was a condition of the study. You had to use olorifim alone, meaning you had to stop the azole, you had to stop the terbinafine, you had to stop the miltefosine and caspofungin, and no matter what you were using. But in the latter stages of the study, you were allowed to use combination, and the data is being analyzed looking at outcomes of patients who received olorifim alone versus patients who received olorifim and combination. And I saw an abstract earlier this year, I think it was presented at ECMID, if I'm not mistaken, showing that the outcomes were very, very similar. This is in the first 200 patients of the phase 2b study. So I'm just, I think Abby is correct. We need that data. And Arun's got his hand up now.
I just wanted, that's a very exciting data she has presented, Abhi, that is about the, in case of azole, the raising this, the possibility of antagonism with olorifim. That is a very important fact which you need to look into, because we generally try to combine in this type of patients. So if this is true, my question was, the terbinafine, which is also working to the ergosterol biosynthesis pathway, I'm not very sure whether it would also work in case of this pyrimidine increasing this particular concentration, because that's a very interesting fact you have brought out.
All right, I think we're approaching the end of our session. It's nearly 9 o'clock. I need to lower my hand. Do I know how to do this? Yep. Okay. Van Hoek, I can't see the questions actually. I don't know why. I can only
Oh, okay. I think there are only two in the Q&A. Most of it have come into the chat.
Oh, I'm looking at the wrong place.
Yeah. Debbie Marriott raises a good point about
Yes.
the recommendation of not needing TDM for a lot of them, despite needing a dose reduction. And I agree with Deb. I think that at least in my skeptical mind, most new antifungal drugs that have come out in the recent times, it's been said that there's no need for TDM. And then I think as time has gone on, we've found that it has been more necessary than first thought because of a huge amount of individual patient variation. So I think it's definitely watch the space as to whether TDM is going to be helpful. And I think it's and Chris has said that there was initially required to have TDM in the original study. But I think just from a practical perspective, accessing that at the moment in a timely fashion that will help impact our care, I think that's troubling at this point in time.
Yes.
Yes, we all agree with Debbie.
Debbie needs to set up the assay.
We're waiting for it.
Help
TDM.
us, Debbie.
Yeah,
Okay. Maybe
yeah.
Sharon,
I'm sure we will need it. I'm sure it'll come.
So
Sharon, you can close the
I'll
symposium, I
close
think.
it. So with that, thank you all for attending, and thanks to our expert panel. Thank you, Arun, for taking time off lunch to join us. And Van Hoek, it's the end of the day for you. I
And
think
for you.
well, it's more than it's evening. That's fine, but thank you to the panel. Thank you to the attendees. Thanks to my co-chair. And we will see you at the next session, which will be sometime in November, and a flyer will go out with all the registration details. Quite enjoyed it, and I hope you have too.
Thank
Thank you very
you. Thank you all. Bye-bye.
Bye.
Thank you. Thank you.